Okay, good afternoon, everybody. My name is Professor Tuấn Nguyen. I am the Principal Research Fellows in the Social Gerontology Division at the National Aging Research Institute. Welcome to our online seminars in aging program. I would like to begin by acknowledging the traditional owners of the land on which we are meeting today. And for me, that is the Wurundjeri peoples of Kulin Nations. I would also like to acknowledge the traditional owners of the lands and water across Australia. I pay my respects to the elders past and present, and to all Aboriginal and Torres Strait Islander peoples, including members of the stolen generation. Firstly, a little housekeeping regarding the MS Teams. At the conclusions of the talk, we will have some time for Q&A. If you have any questions, you can submit them throughout the seminars using the Q&A function, which can be opened using the Q&A tab at the top of your screen. It resembles two speech bubbles, one with a question mark in it. The chat function is turned off, so please use the Q&A function. You are muted and your camera turned off by default. If you prefer during the Q&A, you can raise your hands function in the meeting controls at the top of the screen marked with the hand symbol, and we will allow you to unmute yourself and turn your camera on to ask your question. Today's seminars will be recorded and uploaded to our website within a few days. Please keep in mind, if you turn on your audios and video to ask a question, you will be included in this recording. Today, we will be hearing from Associate Professor Aileen Collier. Aileen holds a joint appointment with the Research Centre for Palliative Care, Death and Dying, Flinders University, and the Northern Adelaide Local Health Network as Associate Professor in Palliative Care and Aged Care Nursing. She has worked as a specialist palliative care nurse in a diverse range of settings and in several countries. Her research program is focused on safety, qualities, and equities of palliative care. Aileen's research interests undergird a commitment to her practical work with moral and pragmatic questions always being anchored to clinical realities. When not at work, you will find Aileen's out in the paddock on the trail with her horses. Today, Aileen will be presenting Older People and Medication Safety, a video-reflexive ethnography in Aotearoa New Zealand. Welcome, Aileen, and over to you.
Thank you so much, and thank you to the whole of the NARI team for having me, and particularly impressive pronunciation of both my name and the word Aotearoa New Zealand. And I'd just like to also pay my respects to all of my Aboriginal and Torres Strait Islander colleagues and friends here from the lands of the Paramount people I'm sitting on right now. And also, because I'm reporting this work from Aotearoa, I pass on tēnā koutou katoa from my Aotearoa New Zealand colleagues, because of course this work is not my own, it is part very much of a team. And although I am sitting back in South Australia and an employee of Flinders University, this work was undertaken back in New Zealand as part of the University of Auckland, where I worked in the TRI Palliative Care Research Group. And these core team members were and are Dr. Catherine Bloomfield, who's a geriatrician and works across Waitemata Health Board and the university, Deborah Bammer, who was my co-field researcher in the study, and Joanna Hikaka, who's a Māori researcher back in Auckland. So what I'm going to do today is really talk about polypharmacy and medication safety for older people as a wicked problem. And then I'm going to problematize some of the current safety and quality approaches in the context of medication safety in older people, and make the case for this thing that many of you may or may not have heard of as an approach called video-reflexive ethnography. And then I'm going to give you a taster of that and how that was enacted in this study in Aotearoa, New Zealand. So my colleagues in the UK, Deborah Swinglehurst, who's a GP, and Nina Fudge, they have spoken about polypharmacy as a wicked problem, comprising this complex tanglement of the biological, behavioural, technical, cultural, and socio-political. And yet we often try and squeeze it into one particular reductive issue, or when it comes to older people, we often position the problem as with older people themselves and through the language of things like non-compliance. And then we often think about this complexity in a way that means we try and separate all these separate parts rather than considering them in this way that Edgar Morin, a French philosopher, talks about this complexity, a fabric of heterogeneous constituents, events, actions, interactions, retroactions, determinations, chance that are actually inseparable. But in the name of wanting control and certainty and a fixing of problems, we try and separate out the parts. And of course, in a local context, and I share this in Aotearoa New Zealand terms, but these data are probably not dissimilar, whether it's any other Western country, Australia, the UK. And again, we talk about polypharmacy in terms of these very kind of ad hoc numbers, 5 or more long-term medicines. And we know that older Maori and non-Maori are often prescribed an increasing number of medications, and people are at risk of significant harm. And the LILACs data from New Zealand really highlighted this. And we also know that the risks and the safety issues are particularly high during care transitions. As a palliative care nurse, it's worth noting also that we're using more medications at the end of life in Australia, probably 30% more than 10 or even 20 years ago. So even at the very end of life, we're using more and more medications. And yet our patient safety and quality approaches, our processes, our organisations have this constant emphasis on measurement, standardisation, stopping any practice variation, data, KPIs, kind of practice improvement, plan, do, think, act, guidelines, except that when we think about older people in frailty, as you know, that we're rarely dealing with one solo illness. It's often a case of multimorbidity, and yet the guidelines find it really difficult to account for those. And then all these other languages of self-care, resilience, human factors. And until very recently, and I would argue kind of put backwards by COVID, we have also excluded often patients and families. And slides got stuck for a minute there, sorry. So this prevailing paradigm where everything we seek to measure and manage really attempts to create these fixed relationships, meanings, realities, or what law calls distort into clarity. And then there's this pretense of control somehow that we can fix these things and make them certain, rather than assuming that we actually are part of these unfolding realities ourselves as researchers, and the way we produce and reproduce our work. So Adams, talking on risk, has highlighted that this kind of focus on formal knowledge really diverts our attention away from the crucial question of how we can all just act in the face of this uncertainty in local circumstances. And instead, we have this constant drive to remove uncertainty. And some of you will know these researchers, and I can never pronounce Trisha's name, but I'll call her Greenhalgh, really recognised that in health services research, in order to study complexity, differently and thinking about different methods. And she has highlighted herself as a GP that this mismatch between the patient in the guideline and the patient in the bed. So they say that we argue that in open systems characterized by dynamically changing interrelationships and tensions, conventional research designs predicated on linearity and predictability must be augmented by the study of how we can best deal with uncertainty, unpredictability, and emergent causality. Accordingly, the study of complexity in health services and systems requires new standards of research quality, rich theorizing, generative learning, and pragmatic adaptation to changing contexts. And as an aside, Trisha Greenhalgh and her colleagues also argue for repositioning and foregrounding the patient and patient safety. And of course, our work way back in 2013 realised that involving and including patients and patient safety was really a moot point, that they are already involved. And when we looked at all of our studies across various contexts, it was clear that patients were already doing safety alongside their families. So herein is the introduction to video-reflexive ethnography, which really talks about gaining a more sophisticated understanding of safety practices and using film and video to film practices to make what is implicit explicit. It also recognizes and spreads success and brings awareness into the fore. The mundane, if you will, are made explicit. The mundane as extraordinary accomplishments. And indeed, why do things go right? Why do they go the way that they go in any particular way at all? And so it positions patients, families, and clinicians as knowledge holders, as well as the researcher. So what video-reflexive ethnography seeks to do really is in the use of film and showing back film to those involved in that film, involved in those practices, including patients and families themselves, is to open up this opportunity for multiple interpretations of the problem, the issue, and see them back from his or her perspective. That generates in turn collective talk and sometimes collective action. And I'm going to share now what that looked like in the context of this New Zealand study. So just to highlight, well, what does this thing VRE look like? The video is sharing practice narratives, filming what is important to clinicians, what is important to people, and really foregrounding affect. but how do people feel? What happens when they watch themselves back in film? Perhaps not even only themselves, but the wider team. So it involves reflecting on practices and using footage of teams' own practices and thinking about and looking at what's happening in a way that might not have previously been seen. So back to our New Zealand study, we wanted to explore and see whether it was at all possible to follow people with a camera in and out of different settings. I think I maybe was a bit crazy for thinking this was even possible. And we had funding from the University of Auckland from a near miss of an HRC grant to do that. And we wanted to explore this in the context of Mason Jury's conceptualization of well-being. And the house here denotes the marae, and Mason Jury is a Maori academic from New Zealand, and this model is very well known in New Zealand to encompass all of well-being, spiritual, physical, mental and emotional, as well as recognizing the whenua, or the land, and the roots of one's well-being. So when I say we, myself and Deborah Banner hung out and recruited people in the Waitemata District Health Board. We invited patients and family, whānau participants of people aged 65 and over, again using this very arbitrary measure of taking 5 or more prescription or non-prescription drugs. And our other inclusion criteria was the frailty category of the gold standards framework. And we set about hanging out on these older people wards, recognizing that many of those people would have cognitive impairment. It was interesting, really, that probably no one on the ward didn't meet this criteria, which was interesting in and of itself, but that the research ethics at the time in New Zealand made it very difficult for proxy consent. And so unfortunately, we weren't able to talk to people even when they had fluctuating capacity. And so we invited GPs, nurses, specialists, pharmacists, and health professionals to sit with us. And for those patients and families we invited to participate on the ward, we asked them, would they be happy for us to follow them over time with the camera, working with them to decide what would be filmed and what wouldn't. So in the end, we recruited 20 older people with an age range of 68 to 89 years, along with their families. And 8 of those 20 people gave us permission to being followed either at home, into their GPs, into the community pharmacy, to their outpatient specialist, and in one case to residential aged care. And so we have published some of these data in terms of what older people told us. And what was really highlighted in this paper was the kind of collective involvement of not one person in medication safety, and that the role of the community pharmacist was often unseen. And depending on the relationship people had with their community pharmacist, if that relationship was built over time, they often trusted the pharmacist over another specialist. And so I just wanted to flag that paper with you. But then moving on from that, we showed this footage back in an impromptu way on site, and sometimes that was a small handful of clinicians, but in one setting, we showed the footage back to the whole of the MDT at Waitemata Older Adult Service. And we leveraged off the morbidity and mortality meeting. And that meeting was facilitated by the geriatrician, Catherine Bloomfield. This kind of happened during COVID. And so unusually we did this as an online session. And I think that was probably of interest in and of itself, that we backed onto the morbidity and mortality meeting, because the clinicians were really high functioning and used to reviewing what went well and what didn't go so well, which became important in this. But really what the key findings of these sessions highlighted was this problem of the blister pack, that it's assumed that the blister pack, actually I'm not sure what they're called in Victoria, Dosette box, yeah, you can tell me in a little while, that there's an assumption that this makes medication safer, when in actual fact, for many people, it made the medication problematic or unsafe, or in fact, on this footage, they realized that they also assumed on discharge that the blister pack meant that people didn't receive other information about their medications. There's also an assumption that it's often one care partner who's looking after medications, when our findings really highlight the complexity of multiple care partners. You know, for this one man, he had numerous family members performing different roles for his medication, and that was informal caregivers as well as the professional caregivers. And really, our findings also showed from these sessions that medication was viewed, even one medication was viewed as having different purposes in different contexts, in different situations. And again, for this man, as an example, the dentist informed him to stop taking a medication, where another clinician told him to restart the medication. And you begin to see how really complex these issues are. And so with the video reflexive ethnography, there's a kind of situated distance where people watch back footage and they can see things that they might not have otherwise seen. And for this one very senior geriatrician, I think this really sums up the kind of response that happens when people can see the complexity of what's going on here. She said, I think for me, it was like we write the prescription and then the kind of impact of it, that it goes into this kind of vacuum space. And there we are at the community pharmacist, and then William is at his home with all the pills on the table, and his daughter and his son are all involved. And this one piece of paper that we generate, yeah, the impact that it has, the potential for good, but the potential for harm. And she's shaking her head, and the number of people involved in administering it. So for her, it was really quite profound. And then with this solution-focused discussion from the MDT, with very little prompting, they started to talk about how they might do better as a larger team in terms of supporting people, older people, on discharge with their medications. And this is just one little taster example that I give here. Now, and I'm probably going over time. So there's still a lot of this to write up and more to explore, and I'm hoping that I just gave you a little bit of a taster today about how video reflexive ethnography, underpinned by the theoretical constructs of complexity, might help us find a way forward to this very wicked problem that is medication safety for older people. And we thank all of the patients and the families who let us follow them in and out of their consults and environments with the camera, and the TRI Palliative Care and End of Life Care Research Group, particularly Dr. Tess Moeki Maxwell and the Komato, the elders, as part of that group. And this was funded by University of Auckland faculty grant. And I will stop there. If any of you are interested any more about video reflective ethnography, come and join us. Would you believe we've got a whole international group of us working in a variety of contexts? And look forward to hearing what people think, comments, questions, or anyone who would like to embark on more VRE in Australia with me, do get in touch.
Thank you very much, Aileen, for great presentations on very important topics, the medication safeties in older populations. We now have some time for Q&A. If you have any questions, please submit them now through the Q&A function, which can be opened using the Q&A tab at the top of the screen. It looks like two speech bubbles, one with a question mark in it, or use the raise your hands function in the meeting controls at the top of the screen, marked with the hand symbol, and we will allow you to unmute yourself and turn your camera on to ask your question. Note, you will be included in the seminar recording if you do this. You can also vote and give thumbs up or other reaction to question via the Q&A function, which will help us to decide which ones to read out and allow you to engage. Remember that the chat function is turned off. I haven't seen any questions in the Q&A yet, so I myself have some questions for you, Aileen. The problems in medication safety in older people have been there for age. We know that the older people, they often have multi-comorbidity, right? And multiple conditions at the same time, arthritis, hypertension, diabetes, etc. And each individual physician, treating physician, they use their own guidelines, but they don't talk to each other. It means that the older patients with the multi-morbidities, they just use the cocktails of medications. So from what you observe via the video reflexive, the ethnographies, methodologies, what do you think we can help the older people to improve? Because it's not only themselves, they are directed to use a cocktails of medications by multiple doctors. So what is the solution for that?
Well, I wish I could tell you all the answers and solutions to them. But I think what I'm making a case for is one way of helping seeing these multiple providers, the impact and the effects on decisions made in isolation, so that we can begin to make a shift on how people relate and communicate with each other. As you know, we've got this health system that's still set up on individual guidelines rather than multi-morbidity. And I think we need some kind of collective paradigm shift to care for older people and their individual needs rather than for the disease. And until we kind of get our heads around that and accept it, I think it's a real problem. I don't think we've even realised in our health system in Nowlan that the majority of people with these needs are older people in our hospital system, and yet our emergency departments, everything is still set up on this single disease. And so I think as a tool, video-reflexive ethnography is one way to make this a lot more visible to the individual and siloed ways of responding to people, and to come up with solutions that are from the ground up rather than reductionist measure and manage solutions that often position older people as the issue. But I'd be interested to hear what other people think. You know, this is probably a group of extremely learned, experienced individuals in the room. But if anybody would like to embark with me on looking at this with bigger dollars across different contexts, do reach out.
Yeah, thank you, Alice. I think, you know, because now the different specialists and GP, they work in silos and they don't talk to each other. And often at the moment, you know, the way physicians treat the patients is focusing on the disease rather than on the person at the holistic point of view. So I think in terms of making coordinations among different providers is very important, and we might need a new model of care where there is some GP or somebody in the healthcare system who can play the roles of a coordinator to coordinate all the activities. Because I know that we did studies in South Australia before, and we look at an older person to see what kind of like the health services they use in 1 year. And we can see on average, they go to see 18 different healthcare providers. You know, and that is something that, you know, without the very good coordinations, it's very difficult to tackle the problems in medication safety. And you also mentioned about the very critical points in time, especially when patients was discharged, you know, in transitions of care. That is where the patient is very vulnerable and they don't know what to do next. And especially the discharge summary is often not detailed enough, not comprehensive enough, providing all the instructions for them to use the medication. And, you know, after you leave discharge, then the change in the medication resume. So what do you think is the best way for us to tackle the problems in the transitions of care regarding the medication safety?
Well, I think a good starting point would be to recognise caregivers in all of this. You know, when people come in and out of hospital or in and out of appointments, their caregivers, who are often older people themselves, of course, are often marginalised or not adequately heard in terms of what's going on. And yet they often have an awful lot of expertise and understanding about the person's medications. And so I think, you know, identifying who those key people are at the outset, and giving an awful lot more power and control back to older people themselves and their caregivers would be a good first step. But I'm really keen to hear other people's perspectives on this, and whether the footage I showed resonated across, you know, could that be a community pharmacy in Melbourne, for example. Yes, I'm interested in anyone else's thoughts about this wicked problem.
We asked the audience, is there anybody can share your experience or thought on the wicked problems of medication safety polypharmacies in older people? Please raise your hands or put the questions or comments on the chat on the Q&A function, please.
Everyone's having their lunch.
Tuan, there are a few more questions in the Q&A if you want to field those.
I can't see anything. From my end, no question yet, so I don't know.
Okay.
Yeah.
So
something wrong with my Q&A function. So can you have to read it
sure.
for me?
So Karen from St. Vincent's Health asks, has video reflex ethnography been used in other aspects of care, such as residential care or hospital settings?
That's actually a great question. Thanks for that. So, yeah, we've used it in hospital settings. And in fact, it originated really in the hospital context. We've used it here in Adelaide around community palliative care, around acute care and palliative care. We have colleagues all around the world using it in various different contexts now. We just had our inaugural video-reflexive ethnography conference. And the residential care one is really interesting because maybe 10 years ago, I would say residential aged care was quite nervous about letting us in with the camera, not surprisingly. But in actual fact, at this recent conference, there's some great work being done in Queensland. An OT, a sort of insider researcher OT, is using video reflexive ethnography in the aged care setting there. And we've just actually got colleagues in UTS in Sydney have a NHMRC grant to use video reflexive ethnography to look at infection control and partnering with older people in the context of residential aged care. So yeah, I think just making a case really for thinking about different ways of research and working that foreground and don't remove subjectivity and affect. So yeah, all different contexts, and do get in touch if yeah, there's another one for aged care settings, and absolutely happy to share papers. Do you believe that polypharmacy can be making the elderly sick? I mean, absolutely. We know this, right? We know, and the problem with this arbitrary number is that 2 medications with high anticholinergic side effects can make people very sick, whereas 7 or 8 very thoughtful, rationalized medications might be okay. But I think Tuan's point, this idea that we're still kind of treating people with one illness is highly problematic. And yeah, we're absolutely making people sick. Yes. I think I've answered all those questions now.
Yep. I think that is all the questions in the Q&A. Any other question from the audience? I have one more question, Aileen. In terms of the ethical, when you use the VRE methodologies, do you come like face any difficulties in terms of like the rejection from the participants, and because I think this is very, very difficult to get consent from many participants when you film them and follow them from the different case setting. So can you give some comment or reflection on that?
Sure. And I think it was particularly, that's why I kind of laughed about it, because I think it's particularly challenging when you're following people in and out of different settings. And of course, our HRECs don't really kind of plan for that uncertainty very well. Having said that, it was possible. So driven by patients and families as the first step, then consent then to the clinician, with the clinician. So for example, ahead of time, knowing someone was going into a specialist appointment or a GP appointment, asking their consent to be involved in the study themselves. Always giving people the option not to participate. And also a strong part of this is you don't have to participate on video necessarily. That's very much situated ethics, and it's never straightforward, right? I remember filming in a room in Adelaide with a community palliative care team, and they understood that what was going on in the room in their huddle with multiple things happening at the same time was really important to film. And so the majority of the room who knew me over time were really keen for me to switch the camera on. But there were two junior clinicians in that room who didn't know me from a bar of soap. And so the tension of switch the camera on or leave it off can be always there. But I think it's the kind of attitude of ethics, the attitude of care and situated ethics, whatever the institutional ethics has said, that matters. And, I've worked with people at the end of life doing this, and mostly people really want to have a voice. So older people want to have a voice. There's one lady who we followed right till she died here in Adelaide because she wanted that as her legacy. And so all too often, I think we sort of gatekeep some of this, when in actual fact, people will often say, show this to anyone who'll listen. Show this to these people over here. This is how ridiculous this is. I want these people to see it. And I mean, my colleagues now are forging the way in aged care now with this work. And, many of these people have cognitive impairment in the work that my colleague is doing in Queensland. And she's using Jan Dewing's process consent, having people with her when she consents older people, even though they've got cognitive impairment. And she's finding actually that they're responding to that process consent very positively and happy to be involved in the filming, which is extraordinary and taking this to another level. So yeah, lots of potential there.
Thank you, Aileen. Any other question from the audience? While we waiting, perhaps I will ask one more question as the facilitators of the seminar. So, Aileen, because when we talk about the medication safety, the quality use of medicine in older people, the first thing we need to consider is to see if a medicine is really needed, right? That is the first principles in quality use of medicine. And, in many cases, the medication actually is not very effective and not really needed. And non-pharmacological therapy can be done in that situation. But why the healthcare provider they keep relying on the medication? For example, people with the BPSD, the behavior and psychological symptoms of dementia, we know that from the evidence-based information, we know that many antipsychotics or psychotropic medications not really helping at all. But why is still the problem? Why the psychotropic medication still prescribed for people with dementia developing BPSD, if even the non-pharmacological therapies hasn't been trialed yet? So what do you think about that?
Yeah, I mean, I think it is not an easy issue, because if you're a registered nurse in an aged care facility and there's only one of you on a night shift to look after 70 residents, it's very, very difficult to tell that nurse not to give a medication or to change the way they're doing things. But even in my own field, I've just published a paper on the use of benzodiazepines in palliative care. And we give out benzodiazepines in palliative care units like they're lollies, even though the majority of our people cared for there are also older people. And so I don't think there's one answer. I think that again, we tend to want a quick fix, and people tend to reach for what they think is maybe the simplest solution. But I don't think it's good enough to kind of pin that on an individual or clinicians. I think it's a cultural and social issue that we need to get our heads around and understand better, and to help, I guess, drive the change ourselves, because I think it's not one. There's not one single cause. But you're right. I see this with my own father and his array of medications, and the cascade effect. You have one for the next side effect, and then that one needs another medication.
By another medication, yeah. Prescribing cascade. Aileen, there are a few more questions coming up from the Q&A. So, for example, with David asks, thanks, Aileen, for an interesting presentation. I'm interested in microbiomics, how the gut microbiome affects drug response and dispositions. Has your team explored this? The question from David Barry.
I'm just trying to find that question. I've just missed that too.
Yes, from David Barry, number 3 from the top.
Oh, yeah.
Yeah.
Got it. Look, David, that's not my area of specialty, but I do know there are Flinders researchers. They actually asked me for advice on this. They're studying the gut and neurology. Look, it's not my area, but they were explaining that, or asking my advice. Do you think this is still? Do you think our study is worth pursuing? And I'm like, absolutely it is. I think we don't understand enough about any of this and the effect that the gut has on these on some of this. And so I think that's why we need transdisciplinary research. We need social researchers like me exploring social complexities, but we need all sorts of different disciplines studying these issues so that we can understand them better. So, yeah, 100%.
Thank you, Aileen. Ross, can you, I think Peter raised his hands before. Can you allow him to unmute and turn on his camera?
Hi, Peter.
Peter?
Hi, Peter, you have to unmute yourself.
I do see Peter's comment, though, that people go to the doctor, GP, to get a present. It's interesting, isn't it, what societal views of medicine are and the expectations of medicines. And how we've kind of assumed as a society what medicines will do for us or not. I mean, no more so in the, like I say, in this space of benzodiazepines and death and dying. You know, somehow we're going to be able to relieve suffering if only we give some midazolam or clonazepam. I'm not shit. Don't get me wrong. I'm not saying that I might want some of that myself, but let's kind of think about how we're using them and judiciously. And how are we asking patients themselves? You know, how are we having the conversations with people? So, Peter, I don't know if you were able to speak.
Peter, if you want to ask the question by yourself, please unmute yourself. Okay, so we might move to another questions. Alison asked you, how can we get in touch with you, Aileen?
Oh, I'm going to give you I'm going to put my email in here right now.
Thank you. Another question, but I just thought that is a comment, a reflection rather from Ling. Anecdotally, I wonder if we need more education around this issue in community health settings for broader allied health team, especially with isolated clients who don't have family or carer to notice.
Yeah, absolutely. I think this is not a one-person issue. I think you know, there's an awful lot of unseen work done. I think the other thing that we need to understand is the way that clinicians enact. I'm getting a reverb on the line now.
I'm getting. Sorry, I've got feedback.
There is a lot of echo from your microphone, Peter. So.
Yeah, absolutely. Broad allied health team, you know, everyone has a stake in this. And you're right, you know, if someone doesn't have a caregiver or a family, I just think some of these people that we met, they would be in hospital without those family members. And I think it's as much about how we support caregivers as well as patients and as well as clinicians.
Okay, thank you very much, Aileen. So please join me in thanking Aileen with your clap reactions, because we're running out of time now. And for next month, Dr. Lydia Brown will be presenting on promoting good mental health over menopause and into older age. So please join us next month on Tuesday, the 19th of August. And thank you very much for attending the seminars in Aging series. Aileen, can you stay for a few more minutes for the debrief section? Thank you. Have a good day, everyone. Bye for now.
Thank you, everyone.